Good morning, everyone. I would like to welcome you to our first Elvis Radial webinar today. We have chosen the time frame regarding the corona situation, of course, and due to the fact that we disbelieve that we will have any opportunity to see each other within the next month. Even the Medica is questionable here in Germany. And therefore, we will have to face the fact that many of our communication will be through this kind of channel. I can see that we have some new faces, new registries on the stream. Therefore, I would like to introduce myself. My name is Hendrik Gronhoff. I'm 48 years old. I do work for Ceramortec and BioLitec since many years, since 20 years. And I'm the product manager for the varicose vein and also for the proctology since 2030. Maybe some words to the history. This course today is rather an advanced course because we are handling 6 topics. I will briefly show you within a flash. And the setup of this webinar is such that only microphone is open, microphone is open, but you have the chance to raise questions on the right-hand side of your dashboard. So be free to write an email whenever you want to. We have a bunch of people registered, like almost 50. So I have my colleague Harris here sitting left-hand side of me to have a closer look to the questions coming up. Should you have any problems with the sound or with the video, we can help you in this issue because from our point of view, from our system, everything should be fine. So last question, Harris, bei dir alles okay, ja? Du siehst alles, was ich mache. So I would like to share with you my desktop. And as you can see, we are talking today about the Elvis Radial webinar, the first one. And the topics. Warum kann ich jetzt hier nicht vorwärts klicken? Clicking. You can see the 6 topics. And just to control again, Harris, sound is good? Video is good. All right. So you can see that we have 6 topics today for the Elvis Radial topic or issue. The first one is something that was of high interest for the questionnaire that I had done before, and it's about the Elvis Radial procedure energy settings. Because people, of course, always ask the question, what would be the energy setting for this kind of vein, for this kind of particular patient? There are some tips and tricks. We will go through this. And actually, in the same topics, energy settings, we're talking about the small saphenous vein treatment. Because the small saphenous treatment is a little bit different to the large or the great saphenous vein. I have quite a bunch of slides for this also into anatomy. I will briefly discuss or explain the Elvis Radial Pro fiber and also the Elvis Radial Swift. Followed by that, we'll talk about 1940, the laser which was launched last year, and the Elvis Smart device, which is a pullback. So when we talk about Elvis Radial today, we are talking about a 2-ring concept, and we're also talking about, you see the mouse? No. And also about a laser crossectomy. That means a flush ablation of the great saphenous vein, for example. This is somewhat different to other users protocols or other competitor protocols. In our newest version of the instruction for use, we recommend to have 5 millimeter distance to the deep vein, to the vena femoralis, whereas, for example, Medtronic is still sticking to 2 centimeters. The glue is far away than that from the junction. And we have limited this from 10 millimeters to 5 millimeter recently. due to several new publications that have come out. And as you can see here, we're talking mainly about two-ring fibers. I will go into detail about the two-ring concept here very briefly, and for a later course we can go to the basics of the fibers in some weeks. So what is the possibilities that you have with Elvis Radial? Of course, as I mentioned, we have the GSV and the SSV, but we also can treat perforator veins, isolated perforator veins, recurrencies, especially recurrencies when people maybe, for example, 10 years ago just made a crucectomy at the junction and the magna or the great saphenous vein is still there, or if you have let's say a tributary which became incompetent after several years of a treatment, no matter if it was crucectomy and stripping or if it was radio frequency or even laser. And some topic is the venous ulcer, you know, the C5, C6 state of the patients. Of course, there are some precautions to be taken to treat the venous ulcer. You have to stay away from the, let's say, bacteria surface and so on. But that's another topic. But this should give you a rough overview about what kind of superficial veins you can treat with Elvis Radial. Talking about the anatomy, we do see here the great saphenous vein, which is coming from the inside and goes all the way down to the inner side of the ankle. And we do have the small saphenous vein, which is on the back side of the calf and is from the backside seen going to the lateral, the outer side of the foot. You can see them here again. Or maybe the accessoric anterior vein. It can be the Giacomini vein, which is normally accessible via the small saphenous vein as a certain form. There are a lot of different veins involved in the junction region, which normally are not treated because they are hardly to be seen. So the main working horse for us is great and small saphenous vein, and maybe, as we know since a couple of years, the main cause for recurrences is the accessoric anterior small vein, which is located here in the region of the calf. The posterior one can also cause some problems, but it's more likely that it's the anterior one. Perforator veins. Perforator veins, as you might know, are connecting the deep vein, the femoralis vein, with the superficial veins like the great saphenous vein or the small saphenous vein. Different perforators in different locations, and it's very seldom that doctors treat isolated perforator veins. Very often the doctors treat, let's say, the trunk and then stay longer at this position to destroy also the linkage leaking point to the deep vein system. Here another picture. Oops, that was wrong. Here another picture, which you can see again, the text is German, but you see here's the deep vein, and then you have a muscle layer, and through the muscle layer you have the connection to the superficial veins. But also there can be perforators in the same plane in the superficial layers. Let's look into the guidelines, because we all know that the laser has a very good recommendation in the guidelines of the Union of the International Phlebologists. You can see grade 1 A, B, C recommendations for the veins that have been mentioned. I would also like to raise the interest for the so-called venous malformations, which are a special form of varices. The absolute contraindications up to now, you can see here. Of course, DVT and an acute phlebitis in the to-be-treated vein, as well as the acute infection, for example, if you have the venous ulcer, or when the deep vein is obstructed and you need the superficial vein as, let's say, a drain. Let's talk about the procedure settings, because for the procedure settings, we've come a long way. And back 20 years ago, people started pretty much from scratch without actually knowing what how to start with the bare fiber systems and the short wavelengths lasers back then. Since 2008, when we launched the radial concept, we found out that the energy that you need to properly treat a vein is depending on the vein diameter. And an easy calculation would be to measure the vein diameter standing. You see, it's an oval shape. And for example, in this example, we are using 10 millimeters diameter. And if you multiply the diameter times 7, this is a straight factor. You always stick to the 7. You get the energy per centimeter to destroy the vein. So you have a 99 point something percentage that the vein is destroyed. Of course, you can now be a P counter and say, okay, the vein is 11 millimeters, the vein is 8 millimeters. The important thing is that you do not underdose. I'm saying this because an overdosing, you will see this later on, is not really a big issue, because if you do a proper tumescence, or let's say just saline solution in cases where the patients are sleeping or under propofol anesthesia, then you hardly have the chance to destroy anything with the laser power. So let's stick to the example we had. 10 millimeters times 7 would be 70 joules. If it's a 15 millimeter vein, 15 times 7 would be something like 105 joules. That means you need more energy because the vein is thicker. Considering what happens if we do a tumescence for this particular patient, then we all know that the tumescence solution, which is infiltrated around the vein, will make the vein collapse. And if you consider a very large vein of 15 millimeters diameter to collapse, then it will not be a very small diameter. It will be a little bit folded. And to reach all the compartments of the folded vein, we need a higher energy. So again, 70 joules for 10 millimeters is fine, but if it's considerably bigger than 10 millimeters, you need to adjust the energy. The same goes for if you just have small tributaries of just 6 millimeter diameters, then you can stick to this formula and say 6 millimeter times 7 is 40 joules. But this is theory, and as you can see, I've written it here. People use everything between 6, 10, and 8 watts, which is a standard, has become a standard. But I have users who use 12 or 15 watts. Or our friends from Italy, they like, or Russia, they like to use 5 or 6 watt only. In the end, all these calculations and process, of course, necessitates some rationale. It doesn't make sense to use a laser with 1 watt and pull very, very slow. And it also does not make sense to invent a 100 watt laser and pull very fast. The regime that we are seeking here, 6 to 10, 12 watts with pulling speeds of, let's say, 5 to 10 seconds per centimeter, is basically what you see in the field. But what is the reality? As I said, we have a formula and we can give this formula to the doctors. But in the end, people work different. They just have one standard setting, and the assistant might choose a second setting in the OR, but they will never choose 5 settings for one particular patient to be changed from starting at the junction, for example, going down all the way to the ankle. And I want to make clear that very often the people who have experience, they will have a tactile feedback on how the vein reacts on the laser energy. For the two-ring fiber, which distributes the energy a little bit more, we have managed to reduce sticking or carbonization effects. But as the laser energy is distributed over, let's say, two rings separated by 6 millimeters, we leave them lying for 4 or 5 seconds in the junction before we start pulling. And the doctors will also feel some kind of answer of the vein when they let the energy act. And very often you see this when you're with the users, that the vein is corresponding to the energy and they have to pull a bit faster. They see, oh, I'm hooking myself into the vein, and then they automatically they will pull a little bit faster. Because as the nature of the beast, the vein diameters at the junction are the biggest, and the most decisive region to be treated is the first 4, 5, 6 centimeters. Afterwards, very often the doctors will choose to pull a bit faster because the vein is thinner and it answers faster with the shrinkage to the laser energy. And as I say, regarding the pullback resistance, the users might pull faster or slower. Looking at the international publications, we see a big variety of energies used. Many years ago in America, people tend to use 20, 25, 30 joules. But also we see people using up to 300 joules per centimeter for the first 5 centimeters. And as you can see here, that would correspond to vein diameter times 30. Why is that possible? Because of the tumor sense. Because if you do in a good tumor sense, then every excessive energy that might come, if a doctor, for example, chooses instead of 70 joules for 10 millimeters, he chooses 200 joules, then the tumor sense, the let's say water compound of the buffer, will protect all neighborhood regions. What are the pitfalls for this simple formula? Is, as we've seen, if you have older people who tend to have a bigger diameter of the vein wall. I'm not talking about vein diameter, I'm talking about the vein wall thickness. And a normal wall is maybe 0.3, 0.4 millimeters. And publications have shown that the older the people get, slightly bigger the vein wall thickness will be. But it's not dimensions. It's instead of 0.3, it might be 0.5. But some doctors believe that this should have an impact. And if you look here at the right-hand side, very important also is the fact that if people had a thrombotic problem before, then you will have a different wall shape and compound, as you see here. And this has been shown by our friend Dr. Manjikian from Moscow in Russia. He has given a talk 3 years ago in the European Venous Forum meeting in Athens, and he was looking at a bunch of 100 people, and in 6% he had a recanalization, and 5 of these 6 people had a prior history of the superficial vein thrombosis, as you can see here, and that's more than 80%. So he was giving the recommendation on the meeting just to double the energy. If you know that the patient had suffered from a superficial vein thrombosis, then it's an indicator for the doctor to address more energy to this vein. As I said, the tumor sense is a very vital point, and I will not talk today about the different modalities you have to do the anesthesia, or the doctor has to do the anesthesia. We've seen everything from femoral nerve block, propofol sedation, water-cooled devices, spinal, local, and so on. Here, our standard is the tumor sense, the infiltration with the solution, doing the anesthesia, some adrenaline in there, which is not favored by everyone, and different compounds to bring in the pH value to a level so it's not a burning sensation. natrium bicarbonate. So talking about the tumor sense local anesthesia, you see that we have a nice killing of the pain. We have a very good contact between the fiber tip and the vein wall. Here you see the compressed vein already. The black parts here is the liquid. We have a thermal buffer to protect neighborhood regions, and also, for example, nerves. Yeah. And looking at the topic treating the small saphenous vein, I would like to clearly say that for the last meetings that we had attended, we could see a movement towards non-thermal treatments, non-tumor sense treatments from the US. We all know that the US works a bit different. You have, I believe, more lawyers than you do have doctors in the US. And due to this case, people are really afraid of having any lawsuits referring to their treatment. And this is why, of course, Medtronic is pushing the glue. But at the same time, we've seen that Merit Medical, company making $1 billion, has bought MOCA, the Clarivane device, which is working with a rotating catheter and polydocanol or foam to have a more precise or higher success rate foam sclerization. We believe that this movement is totally wrong. There is no need to be afraid of the thermal applications. And I'll briefly go through the anatomy with you so you know where to start the laser and what to regard when finding the access point or the so-called risk point. Because compared to the great saphenous vein, the small saphenous vein is accompanied by nerves. For the great saphenous vein, the saphenous nerve is separated in the upper part and it's coming towards the great saphenous vein in the knee region. Looking at the calf, so everything below the knee, as you can see here, we have the tibialis nerve and we have the suralis nerve. These are the two nerves, apart from others, which are of interest for a doctor when he's treating the small saphenous vein. And the guidelines, they do recommend to access the small saphenous vein not deeper than mid-calf level. This is not just because of the laser energy, it's also because of the risk to destroy or harm the nerve with your needle to access the vein. So looking a bit closer to this, you do see the situation for the nerves and the veins. You see the suralis nerve here. You see the vena saphena or the small saphenous vein, which is here. And the suralis nerve actually, as we see in the picture, is changing its appearance over the length of the calf. Here we are behind the knee region, and you can see that we have the tibialis nerve, which is a strong nerve here, and it's very nearby the vena poplitea or the extent, the small saphenous vein, which is has been erased here. The tibialis nerve is going all the way from the ankle until, it goes all the way until the sphincter. It can even be used to do some sphincter stimulation in case of incontinences. But looking back at the veins, the nerves that are of interest for us when treating the small saphenous vein, you see here the knee region above the knee. And we see here the vena saphena parva, which is the small saphenous vein, and the tibialis nerve is already away from it. But you see here a cutaneous nerve, the suralis, and this is one part of nerve which is entering the fascia where the small saphenous vein is lying. So again, you see here the knee level. If we follow it a bit below the knee, Then we see the tibialis nerve is here. We see the vena saphena parva here with a very small vein nerve. And a little bit deeper, we see the same situation again, where we have the suralis nerve all of a sudden very close to the vena saphena parva. And this is actually what the guidelines mean. Here you see, oh, the vein is very close to the small saphenous vein. And at the ankle region, again, we see the parva here. And we can see that the other nerves are gone. So that means the decisive part is below the calf. I will later on share with you a publication from some Turkish colleagues who have tried to do a little study about this so-called risk point. Is it safe to go in the mid-level of the calf to enter the small saphenous vein? And just to give you an impression, here you see some ultrasound pictures. And here you see the sural nerve, and here you see the vein. They're in close proximity. It would be very dangerous to treat the vein without the proper separation from the nerve. Here another picture, and here you see that the sural nerve is away from the compartment. It's outside here. Here you see the compartment of the small saphenous vein, which is located here, and here you see the sural nerve already several millimeters away. And here at another point, we see that this is just another situation where you see the small saphenous vein here, and you see two branches of cutaneous nerves, which will later on, more distally, form the suralis nerve. From these two nerves, a little bit below the calf, you will see a joining, and this is then the very dangerous part. Therefore, what I'm trying to say here is that to treat the small saphenous vein, your ultrasound experience needs to be very, very good. And it should not be given to rookies who do not know what are nerves and what are the veins, what is compressible, what is not compressible. So I want to raise the attention that the people take a close look. Where are the nerves, especially the suralis nerve? Where is the suralis nerve forming from the two cutaneous branches that you see here to enter the nearby of the vein? This is from last year, a Krakow meeting of the UIP, and there was one talk, and in their 250 patients study, they could find 100% possible separation of the sural nerve from the vein in 100% of the cases. Yeah, and as this doctor was saying, we need a very good mapping before we start the treatment, and any affection of the nerve was reduced to below 1%. So as we all know, it's not only critical to place the fiber in the sapheno-popliteal junction below the knee, because here the doctors also should have 1.5 to 2 centimeters distance to the popliteal vein. And as I said, especially the suralis nerve is nearby the vein, and the doctor needs to have a close look. Where is the nerve very close to the vein? Where do I have to add more tumescence or saline solution to do this mentioned hydrodisplacement of the sural nerve? And of course, the thermal energy must be adapted. And this is something where we recommend mainly to use 50 joules for the treatment of the small saphenous vein. I will now start a little questionnaire to ask you, what are your expertises? What are your experiences in using the laser energy setting for the small saphenous vein? I've been giving you here 4 answers, so it's not a kind of test, don't worry. But it would be interesting to share from your experience how many patients do get more than 50 joules, or if you always stick in a certain regime. Yes, and while we do this little questionnaire, I would, after we finish this here, I would briefly go through the access point so you can see what we mean with, let's say, the risk point. That would be in a flash. So we have a strong center at 70 joules maximum. Yeah, that means most of the users outside, you people, our valued partners and colleagues, go above 50 joules. And I think you stick to this because of the good tumor sense. So you can see that the people are not having problems if they have energies of 70 joules, which is a good sign and shows that your users are fit enough and clever enough to wisely choose the tumor sense. All right, I will close the questionnaire. We will share the results later on. I will just briefly show you the Elvis Radial Slim. Like to share my screen here again, because now we're talking about the Elvis Radial Pro Fiber. The Elvis Radial Pro Fiber is very fresh. It came on the market in, I think, end of November, and it bears a flushing function. I'll be back in a flash. I'll just catch a fiber. I think it might be nice for you to see it one-to-one. Just a moment. So the most important thing is actually that this kind of fiber, it's a regular Elvis Radial 2-ring fiber with a 400 micron core. As I said, 2 rings, and we have the typical markings. But around the fiber, we do have a tube. You see a tube, and this tube is accessed via this T connection at approximately 1.10 meter distance from the distal fiber tip. And with this Lüller connection, the doctors can also bring in liquid, as we write in our instruction for use, or foam. And the situation for this type of fiber is such that, of course, the basic idea was to bring in some water to flush out remnants of blood. But you can see my blinking eye that people use it with a foam. And actually, looking at it, it gives you actually the chance to mix the thermal energy laser protocol with foam. For example, if you have a tributary, if you have a perforator, if you have very tortuous side branches which cannot be assessed from the laser. Yeah. So in the instruction for use, we are writing that you should flush it first with some saline solution to make sure that all the links and the transitions are okay. And then you keep the syringe with the water connected. Because if you forget to flush it with water at the beginning to bring on some certain pressure, the blood in the vein, if the fiber is placed, it might be running back in between the laser fiber markings and the outer tube. And that would not be recognized at the beginning, but as soon as you pull out the fiber from the vein, all of a sudden it will be occupied with blood. So the doctors don't have the markings anymore. So to prevent that, we recommend to put some pressure on there with saline solution. And as you can see here in the picture, the saline solution would also get rid of some blood, or maybe even make, let's say, a strongly curved vein a little bit more straight to pass by certain, let's say, narrow points. But of course, doctors will do the same as they do for the venous closure fast catheter, because as the venous closure fast catheter offers you to apply a thin guide wire, they use the same connection to put some foam through. Now, the closure fast catheter has a very, very small lumen of just 0.55 millimeters. That means if you put in foam, and everyone who knows a little bit about foam, then most of the foam at the exit, due to the pressure and small dimensions, might transfer to liquid again. It has never been a problem for the doctors. Here we have a larger surface with our concept, so you will have more likely to have the complete foam at the end of the laser fiber tip. Looking at the fiber a little bit closer, you see here the outer tube, and if we go into a zoom, you see here the fiber tip, and you see maybe a little bit translucent the outer tube, and the tube ends here where the black safety marking also ends. So this is the point where a foam or a liquid would leave the laser fiber. Here just some pictures from last year's Krakow meeting. This was the first instance where I saw a doctor talking about using foam with the venous closure fast catheter. Medtronic does not mention it in the instruction for use, so do we, and you will not see any publication about this issue because it is an off-label use. And as such, I want you to regard certain points when using the Elvis Pro fiber with foam. In case doctors see, oh, it makes sense, I would like to use the fiber in conjunction not with saline solution but with foam. Then it's their obligation, it's their responsibility. It is an off-label use, the same as it would be with Medtronic. So looking at the possibilities of foam, there is an interesting publication I will later on share from Japan, where they were doing combination therapy, doing the veins with the laser, but also treating the vein with sclerosing foam. So whenever they were using the foam, they were stopping the laser for a moment, as you can see here in the scheme. They were here doing the first part of the great saphenous vein. Then there was a tributary going away, so they were putting in the foam. The good thing is, if you occluded this part of the great saphenous vein, this access point for foam is blocked, so the foam has to go the easiest way. And that in this situation would be backwards, but there's the fiber in the, let's say, tumescence compressed vein, or it would be the tributary. The same goes for a further down position. When they started the laser, did this tributary, did laser again, and then comes the next target tributary vein. I've just by accident talked yesterday to a Swiss power user of the Pro fiber, and he says it's no problem to do the foam at the junction and later on at the knee or even below knee, because our foam passage is not blocking. And this can happen for Medtronic. I've heard German users who said, I can do once, but then due to the clotting of the blood, due to the small caliber it's occupied. I cannot bring in more foam. So this paper I will share later on with you. And looking at foam, we have to regard, of course, also the guidelines, and that would be that we say the maximum amount per patient per leg would be 10 milliliters of foam for the total leg. That means, for example, 4 trunks above 5 millimeters, they use up to 2-3 millimeters with 4 or 5, let's say, punctures per patient. But if you apply this amount of foam, you need to know that we are losing a little bit of the foam inside the lumen. Because as you can imagine, this is the length of 1 meter. Yeah, in between the laser fiber and the tube, there is some space, a dead space, so to speak. And this space is occupied by the remnants of the foam, which is staying inside. The amount, including the little hub here of the TPs, is approximately 1.3, 1 to 1.4 millimeters total. That means if they apply 5 milliliters of foam, 3.5 milliliters will definitely get into the target vein. And the risks for foam, you need to know this, are common. We have a very low rate of anaphylactic shocks, asthma, or headache, or pulmonary embolism, and it's slightly higher for deep vein thrombosis. So you need a patient consensus for this as well. Now that we are talking about the Elvis Pro fiber, and here a picture of the two-ring fiber again, I would briefly mention why we invented the two-ring fiber. And the reason was to separate the energy and to reduce the possibility of sticking or carbonization. That's basically the concept of the two-ring fiber, to diminish the energy on spot into two equal portions of 50%. Means if you choose 10 watts with a laser device, then every ring will have 5 watts. And due to the separation, we have less energy and less temperature peaks. So looking at energies, I know there are any physicists around, but the energy density for the old bare fiber concept was more than 3,000 joules for a 50-watt machine. With the radial concept, we can bring this down to a factor of 1/9 of this, and by separating the energy into two equal portions, we are going down to less than 200 watt per square centimeter. So you can see here the big changes that we have reached over the last 12 years. And to really vaporize tissue, the physics says you need more than 500 watt per square centimeter, and we are already below the radial fiber with this. I can understand if especially the new partners out there are irritated by the abundance of different fibers that we have. And I'm just trying to give you a little overview here before I mention the Swift fiber, because we started with the standard fiber, which is a 600 micron fiber core. We have the Swift fiber, which is pretty fresh in the armamentum of our product range, and we have the slim fibers. And on top of that, almost all the fibers are also available as a two-ring version. Looking at this on a table, you see here that for the Elvis Radial Slim Fiber family, we have an outer diameter of the cap. We're always talking about the biggest diameter, which is the cap, is for the Slim Fiber 1.2 millimeter, and we'll be using a 16 gauge introducer for this system. The power for the Slim Fiber or two-ring Slim Fiber is 7, respectively 8 watts. And in the instruction for use, we have a maximum energy of 70 joules for this type of fiber. It still is glass. The quality is outstanding. We have a very, very tiny amount of problem with the Slim Fiber, mainly if people use it and mechanically clean it or use it for 2 or 3 truncal veins, putting in 5,000–6,000 joules for these fibers. As you see, it has a 400 micron fiber diameter. This is the same for the Swift and the ProRing fiber. Only the standard fibers, they do have a large vein fiber diameter. Why is this important for you? It depends a little bit on the age of the lasers. Most of you will use Ceralas E or Leonardo lasers, which all have the ability to go with 400 micron. But some old machines, they might only accept large fibers, and for some market it might be interesting or at least important to have an eye on this. There's a little mistake I can see here, because looking at the numbers, of course you can use a 4 French introducer for the slim fiber, I'm sorry, and the Swift fiber, as you see, is slightly bigger than this. And the good thing about the Swift fiber is that for people who like to be cheap with a 1-ring fiber concept, not using a 6 French or 5 French system, they can use the Swift fiber with a 14 gauge needle. I will show you pictures soon. It is slightly bigger, 0.3 millimeters, and this fiber bears more maximum power of 10 watts. Then we've seen the Pro fiber, 6 French, normal cap diameter, and you could use it up to 15 watts. It has a 400 micron core, and the standard, the first radial fiber from 2008, the 1-ring or the 2-ring, comes also with the 6 French introducer, but with a 600 micron core inside. So looking at this, the appealing thing for the direct access, of course, is to be able to use a 14 gauge or 16 gauge indwelling catheter, because with the ultrasound you access the vein, you can have multiple puncture sites, yeah? Especially when you have tortuous vein. Doctors really appreciate the fact that you just buy a bunch of 16 gauge or 14 gauge needle Vasofix safety from Brown or whatever, Beckman Dickinson, and then they can directly access the veins. This can also be good for perforators, isolated perforators, or for recurrencies, stumps in the groin, which maybe are just 1.5, 2 or 3 centimeters. Bringing in a fiber via the introducer set is not as easy for those cases. Yeah, I would like to also share with you some information about the new brochure that we have. And in the brochure, as you can see here, we have implemented a new motif. It's mountain climbing, and you see on the top of the mountain, we've not reached the ultimate top though, we have the 1940 lasers. On our way to our level here, we've of course noted all the other bigger achievements. For example, the 2-ring fiber, the slim fiber was invented here before, but this is actually the topic behind choosing the climbing. Yeah, because for climbing you need to be able to trust your material, your gear. You have to have the right material for the right path. You have to be able to adapt it. And last but not least, you have to trust the material. That's why we are focusing also on the fusion, the tight welding of the laser fiber with the laser fiber cap. But let's proceed with 1940. What is the secret and the story behind 1940? We all know where we're coming from. We were coming from diode lasers, which had a strong absorption of blood, which is here the red line. And since the achievement of 1470 in 2006, we have reached a water absorption peak at this position. The water absorption compared to the old lasers, for example, is 100 times compared to 810 higher than for the old lasers. And looking at 1940, again, there is another peak. And as this is a logarithmic scaling, we've looked into the details, and what we see is actually this here. As we track the water in the vein wall and the blood, we have a 40 times higher absorption compared to 980, and we have a 400 times higher absorption compared to 810. There are still lasers of this kind around. This goes for 1470 compared with the old wavelengths. But looking now at 1470, we have approximately 4 to 5 times higher absorption coefficient in water compared to 1470. What does this mean? It does not mean that this 1940 laser is just entering the vein 1/5 or 1/4. Due to scattering processes, we have similar effects in the vein wall. But after using this device for several years, especially with our friend Uldis Maurits in Riga, we found that there are some slight differences. And the main differences are that the lessons we learned is that the occlusion rates are similar and the complication rates as well. Even for pain, there seems to be no difference. But we have a lower treatment power of 8 watts instead of 10 watt, the standard protocol for Uldis. Why is that? Because the correspondence of the vein, the shrinkage, is slightly more instantly as for 1470. The energy used is actually the same. The carbonization and sticking seems to be reduced to 0, and we have a faster resorption of the treated vein segment. That can be also possible to treat more superficial veins, because if you have some kind of matting or shadowing, then the resolving of the vein seems to be much faster. Normally we have 90% resolving of the cord after 12 months, but here it seems to be something in the range of 3 to 6 months. But this does not seem to be the only difference, because there are some rumors out there that 1940 can be used without tumescence. And in the same meeting, which I've already mentioned in Krakow, there was a doctor from Poland, and he was giving a little overview about 1940. And of course, the success rate was outstanding, 100%, occlusion rate in all controls, no recanalization for energies greater than 30 joule. This is already remarkable. But the second thing was more important. He was talking about the possibility to do the thermal laser ablation without a tumescence. And this Polish doctor, he reported that he could do it in 38% of the cases. It was a very small group, as you can see here, without tumescence. And how does this work then? I will tell you. They're using 1940 as a laser power for watts. The patient is awake, no tumescence, done. They start the laser, and as the patient notices pain, they will reduce the energy to 3.5 watts. They will try again, and if the patient still notices pain, they will reduce the laser power to 3 watts. And if he then still has pain, they will give a tumescence. In 62% of the cases, they had to do the tumescence after following this protocol. So from our point of view, there might be certain patients who might accept to be treated without tumescence, but the danger is that the doctors are using very low energies, and 30 joules for a vein treated, for example, with a large diameter, with the blood still lying in the vein because it is not compressed, we do not believe that the occlusion rate can be acceptable high enough. We've done some own tests with freshly stripped veins, and we could see that if there is just a small amount of liquid inside the vein, it could be blood or water, then a lot of energy of the 1940 is absorbed and is not reaching the vein wall, which is not what we want. So our saying is we only recommend 1940 with tumescence. We have a 10 watt device out there, and we always like to have some extra power. Some competitors offer 6 watts and then use this with 3 or 4 watts. We disbelieve in the non-tumescence approach, and time will tell. Okay, I would then start another question about the 1470 competition. And I would ask you to answer this short polling to see if you see 1940 companies in your market, in your territory, to maybe offer this as a new fancy thing after 14 years of using 1470. It would be interesting to learn from your experience again what you can share. Here in Germany, we have mainly a very small company who started the talk. Then, of course, we might have Neolaser, we might have Metroon, and some other companies in the East Bloc offering 1940. We offer it as well because it is the new kid in town. There might be some ideas to replace the 1470 lasers for the doctors who always want to be cutting edge. We're pretty sure to together with you offer a trade-in possibility, but I want to make you aware that the 1940 laser is considerably more expensive by 20% than the 1470 nanometer laser. I can see that more than half of the people corresponding here have seen no competitor. I think this was also the reason why the interest for 1940 was a little bit lower than for the other topics. I thank you very much for your answers. And I will just briefly show you a little video, which you can see how to use the Elvis Smart device for the ones among you who have not seen it yet. So,
the pullback device can be used with the mini laser, the Leonardo laser, or the Ceras E laser. The pullback setting in millimeters is done with this switch. You have 4 speed possibilities. The pulling direction is from the left to the right, and the indicator shows you when the fiber is being moved. Placing a fiber is the standard way. You open up the upper lid and integrate the fiber into the belting system, which makes the fiber move. The good thing is that the laser device and the pullback device are controlled by one foot switch only. As you see again, the pulling is from the left to the right.
So the pullback device can be a nice solution for the lazy doctors, because we all know that Medtronic is still active, and many doctors who grew up with venous closure fast, they are you don't have the picture. Thank you, Harris. Thank you. And many of these doctors are lazy. They just like to press the button. And here we offer a solution maybe to get into this mentality of the doctors by offering a pullback device which does the job for them. The good thing is they just have to press one foot switch, and the foot switch is activating the laser and also pulling the fiber through the vein. We have 4 different speeds. Mainly the people will use 1 millimeter per second, which corresponds, for example, for 70 joules to 7 watt laser power, and 1 millimeter per second would end up 10 seconds per centimeter, in total 70 joules. So the pullback device would be the last topic. I have one more polling. I would like you to answer, so you're not falling asleep if this is too boring. So let's see how the people answer to the last poll. And maybe I should also mention that the pullback device is used from Dr. Maurens and especially in Belgium and some other European countries to a small extent. but if the people once start, they stick with it, because there's one more thing to consider is if you imagine a doctor pulling a vein fiber through the vein, he will do this for a couple of centimeters, but at a certain point he will have to regrab the fiber a little bit more proximal to the body. And this is a very short time frame where he's not releasing the foot switch. That means he might stay with the laser on a position for a second. That, from my point of view, could be the reason why sometimes the fiber sticks more. And the pullback device, of course, fulfills the promise to have a complete protocol where you always have the same energy and always have the same pulling speed throughout the complete vein. So I can see that you're a bit invariant. Some people say definitely good thing, others say the same extent no, but the majority says maybe, to convince some closure users. I would be happy though. That would be the end of today's session. I hope you liked it. We did this the first time, so I will send you some presentation. I will put it in the Dropbox. The complete video will be put into Dropbox later on. And in the next weeks, of course, we will offer more webinars for the topic Elvis, but also for proctology. So for the moment being, I would like to thank you for your time, for your patience, and I hope you take some home message for you, and we'll be in touch. As I said, I will later on send you some publications and the complete presentation as a PowerPoint. We had the chance to have some questions here. I can see there are no questions at current on the screen. Yeah, could be a good sign, could be a bad sign. We will learn. So thank you very much. Stay healthy, and I hope to be seeing you, if not this year, then next year again. Goodbye.